Hello everybody, welcome to lecture 18 on the female reproductive system. Okay, this is going to be a follow-up to our last lecture, which was on the male reproductive system. So the female reproductive system is more complex than the male system because it serves more than one purpose. Okay, the purpose of the male reproductive system was to produce and deliver gametes, and the female reproductive system does that. Okay, but it does a lot more than that as well. It also provides nutrition and safe harbor to a developing fetus. It eventually gives birth to a fully developed baby. Okay, it can even nourish an infant after birth through lactation of breast tissue. Okay, female system is cyclic compared to the male reproductive system, and hormones are secreted in a much more complex sequence, which we will discuss later. Okay, so we had mentioned in the last lecture that the two sexes are pretty indistinguishable for the first 8 to 10 weeks of development. The female reproductive tract will develop from what we call the paramesonephric ducts, and not because of any positive hormone action, but because of the absence of certain hormones like testosterone and MIF, which is Mullerian inhibiting factor. The differentiation between sexual development will be determined with the lack or presence of these hormones, and testosterone is one of those hormones. Okay, if you do not have testosterone present during the development of a child, this causes the mesonephric ducts to degenerate. It will cause the genital tubercle to become the gland's clitoris. We spoke about that in the previous lecture. The urogenital folds, instead of surrounding the urethra, become the labia minora. The scrotal folds, instead of becoming the scrotum, become the labia major in the female. Okay, without MIF, okay, these paramesonephric ducts develop into uterine tubes, the uterus, and the vagina. Okay, so the lack of these hormones are going to allow female organs to form rather than male reproductive organs. Okay, the internal genitalia of the female reproductive system are the ovaries, uterine tubes, uterus, and the vagina. Okay, the external genitalia are the clitoris, labia major and minor, and associated subcutaneous glands and erectile tissues. Okay, all of these external genitalia occupy the perineum, which is that space between the thighs, okay, which we looked at in the last lecture, and we will look at it again in this lecture. Okay, once again, the primary sex organs are the ovaries. Those are going to produce ova, or the gametes, and the secondary organs are the other internal and external genitalia besides those ovaries. Okay, so here is a section of the female reproductive system. Okay, and we're going to need to know much of this, and we will go through all of this as we go through the chapter or go through the unit. Okay, but we will hit most of these landmarks as we get to them, as we go through. Okay, so the ovaries, let's start just like we did with the male reproductive system. We're going to go through the different structures, give you their functions, things like that. So we'll start off with the ovaries, which are the female gonads. Okay, let's not forget that. They produce eggs or ova, and they also produce sex hormones for females. Okay, they are almond-shaped, and they are nestled in the ovarian fossa of the posterior pelvic wall, so they are towards the back of the pelvis. Okay, each egg develops in its own fluid-filled follicle, and when that follicle bursts and that egg gets released, that is what we call ovulation. So if you are looking to have a baby or get pregnant, ovulation is the time where that has the greatest chance, or the only chance of that happening. Okay, there are certain ligaments that hold the ovaries in place. Okay, the ligaments of the ovaries are attached to the uterus by the ovarian ligament. Okay, they're attached to the pelvis by suspensory ligaments. Okay, and ovaries are going to contain ovarian arteries, ovarian veins, and ovarian nerves. Okay, the ovary receives blood from two major arteries, the uterine artery and the ovarian artery. Uterine artery and ovarian artery. And that is equivalent to the testicular artery in males. Okay, so here is an ovary. Okay, this is almond-shaped gonad, very similar to the shape of a testicle. Okay, we see the formation of a follicle. Okay, here's our ova. And as that follicle matures and gets larger, and eventually it bursts, and therefore releasing the ovary or the ova into what is the fallopian tube down here, okay, which leads to the uterus. Okay, but once that ova gets released into the fallopian tube, that is when ovulation begins, and that egg is ready for fertilization. Okay, here's the suspensory ligament with the associated blood vessels going through it. Okay. Okay, the uterine tube or the oviduct, it's also called the fallopian tube. I will refer to them most of the time by the fallopian tube, but they are called all three of these things. Okay, it's a canal about 10 centimeters long from the ovary to the uterus. It's muscular. It's lined with ciliated cells to help that egg travel from one place to another. Okay, here we can see another view of the same thing. Here's the entire female reproductive system. We're looking at it as a frontal view right now, and we can see all the different parts, but you can see the ovaries on either side here and here. This is a cross section of that ovary and the fallopian tube. So here is the fallopian tube, okay, which is this. Okay, here's the fallopian tube that leads from this ovary. So when that follicle bursts and that ova is released, it is released into the fallopian tube. Here you can see the cilia and the musculature of that fallopian tube inside. Okay, here is a dissected human female reproductive system. Okay, intact. Okay. Here's our ovary. Something to go forward. Okay, here's my ovary on this side. Okay, ovary would be over here on this side. Okay, and you can see the fallopian tubes here, which lead down into the uterus here. Okay, and we'll be looking at that picture again later on. Okay, so the uterine tubes or the fallopian tubes have some major portions to them. Okay, there's the infundibulum, okay, which is the flared trumpet-shaped distal end, or the ovarian end. That's the one closest to the ovary. Okay, we have the fimbriae, which are the feathery projections of that infundibulum. Then we have the ampulla, which is the middle or the longest part, and then the isthmus. Isthmus is the narrower end that is towards or closer to the uterus. Okay, we can take a look at that on a picture. Okay, go back to this picture. Okay, we have here's the uterus here. We got a pen. Okay, here's the uterus. Okay, here's the isthmus, which is the part of the fallopian tube that's closest to the uterus. We have the ampulla, which is the middle region of our fallopian tube. Infundibulum, right here. This area here. It's that horn shape. And then we have the fimbriae, which are these like little finger-like projections that catch the ovulated ova after it ruptures from the follicle. Okay, the uterus itself is a thick muscular chamber that opens into the roof of the vagina. It usually tilts forward over the urinary bladder. It harbors a fetus when the female is pregnant, provides a source of nutrition, and expels the fetus at the end of its development. Okay, so The fact that it sits over the bladder, okay, the reason why pregnant women have to use the bathroom all the time is because when the baby is growing, it's sitting basically on top of the female's bladder, which is going to reduce the amount of volume that the bladder can hold. Okay, so female pregnant women tend to have to go to the bathroom a lot more often because their bladder is kind of being squished by that developing child. And as the pregnancy goes on, the child gets bigger. It makes the bladder even smaller. Okay, that uterus is muscular, and the contractions of those muscles are what project the fetus out of the uterus during childbirth. Okay, it's a pear-shaped organ, and there are three major portions of it. There's the fundus, which is the broad superior curvature. Okay, it's on top. Okay, you have the body, which is the middle portion, and you have the cervix, which is the cylindrical inferior end closest to the vagina. Okay, so once again, okay, here's the fundus, just like the fundus of the stomach. Okay, this superior curvature. And we have the body. Okay, and then we have our cervix here. Okay, cervix is right. It's like kind of where the vagina ends and the uterus begins, right there. We need to be able to label all these for our exam. Okay, a pap smear. This is a very regular thing that females have to do at the doctor's office or the OBGYN. And a pap smear is when doctors collect loose cells from the cervix and the vagina, and they are microscopically examined for any abnormalities or for any diseases. This is the best protection against cervical cancer because it allows for early detection if you get pap smears regularly. I think once or twice a year is the normal routine to get a pap smear at your OBGYN. Okay, they are not the most comfortable things from what I understand, but they are very necessary. This is like the equivalent of like a prostate exam for a male. Okay, the more often that it gets done, the better chances you have of catching something that's not right and getting it fixed. Okay, there are three grades of cervical intraepithelial neoplasia, or abnormalities of the cervix. Okay, you have class 1, which is mild dysplasia, class 2 dysplasia, which doctors will typically order a biopsy where they will take cells and look at them for cancer, things like that. Then you have class 3, which results for a call for radiation therapy or a complete hysterectomy. Complete hysterectomy is when the uterus and ovaries and fallopian tubes are all removed. Idea there is that you can't get ovarian cancer if you don't have ovaries. You can't get uterine cancer if you don't have a uterus. And if you are done having children, the idea is that if you're not going to be using those organs for reproduction anymore, the safe bet is to take them out. Right, the best way to prevent cancer is to take those out. So that's an option. It's something that people don't like to do. Okay, but it is definitely an option that will greatly reduce the risk of certain cancers. Okay, there are 3 layers of the uterus. There is the perimetrium, the myometrium, and the endometrium. Okay, the perimetrium is the most external layer. The myometrium is the middle layer. Okay, and that's where all the muscle of the uterus is going to be held. Okay, it's going to constitute most of the wall of the uterus, and it's composed of mainly smooth muscle. Okay, it's not skeletal muscle, it's smooth muscle. Okay, and this is what produces labor contractions, and that's what, like I said before, expels the fetus during pregnancy, is the contraction of these smooth muscles during childbirth. The endometrium is the inner layer, the innermost layer of the uterus. Okay, this is going to shed each menstrual cycle or each menstrual period, which we'll talk about later. Okay, the basal layer of the endometrium is the deep layer, which generates new functional layer after every menstrual cycle. So once the functional layer is shed, okay, the basal layer will regenerate a new functional layer. And during pregnancy, the endometrium is the site of attachment of the embryo. Okay, that's where the embryo is going to form during those 9 months. And that's where the placenta will form as well. And that will nourish the fetus. Okay, the vagina itself, or the birth canal, okay, that we can call it the birth canal. Okay, it's about 8 to 10 centimeters long. It is distensible, which means it can stretch. Okay, and again is also a muscular tube. Okay, it allows for discharge of menstrual fluid. It's going to receive the penis and semen during sexual intercourse, and it'll also allow for birth of a child. Okay, the outer adventita, the middle muscularis, and the inner mucosa, these are the different portions of the vagina, which we will talk about. The vagina is tilted posteriorly between the rectum and the urethra. Okay, the fornix is the blind-ended space at the top of the vagina that extends slightly beyond the cervix. There are transverse friction ridges or vaginal rugae, kind of like a rugae in the stomach. These are like folds. Okay, these folds are towards the lower end of the vagina. And then we have mucosal folds across the vaginal opening called the hymen, which many times is ruptured during sexual intercourse. Okay, the vaginal epithelium undergoes what we call metaplasia, which is the transformation of one tissue to another. So as a child vaginal epithelium is simple cuboidal in nature. And then as estrogen is produced during puberty, okay, those simple cuboidal cells are converted or transformed into stratified squamous cells. Bacteria ferment glycogen-producing acidic pHs in the vagina, and that will inhibit the growth of pathogens in the vagina during puberty as well. Okay, and that all happens during metaplasia. Okay, the external genitalia of the female reproductive system are collectively called the vulva or the pudendum. Okay, so the Mons pubis. The Mons pubis is a mound of fat over the pubic symphysis, bearing most of the pubic hair. Okay, we'll call that the Mons pubis, the area where the pubic hair would be located. Okay, we have labia major, which are a pair of thick folds of skin and adipose inferior to the Mons. Okay, we have labia minora, which are thin hairless folds medial to labial majora. Okay, the space between forms what we call the vestibule, and that vestibule is going to hold the urethra and vaginal canals or openings. And the anterior margins of the labia minora join to form a hood-like prepuce over the clitoris, which is homologous with like the foreskin of a male. Okay, the clitoris itself is considered to be erectile tissue. It is a sensory organ. Okay, very much like the head of the penis. Okay, very similar developmental structure. This is the primary center for sexual stimulation in a female. Okay, it also has a glans, a body, and a crura. Those are the three portions of it. Okay, there are vestibular bulbs, which are erectile tissue deep to the labia major. These bulbs, as well as the greater vestibular glands, open into the vestibule and allow for lubrication of the vaginal canal for sexual intercourse. The lesser vestibular glands will also provide lubrication as well. And then there's the paraurethral glands, which are the female version of the prostate, okay, which are going to help lubricate and prepare the vagina for sexual intercourse. Okay, again, here is the perineum. Okay, that diamond area there. Okay, we can see the Mons pubis here, that area where the pubic hair would grow. We can see the prepuce, the hood here for the clitoris. Here is the clitoris here. okay, which would become in a male the glans penis. Okay, we have our labia majora on the outside, labia minora on the inside. Okay, we have our vaginal orifice. We have the hymen is here at the base, closest to the anus, and we have the vestibule, which is the opening here. Okay, just to give you an idea of anatomically where this all is, you can see the structures of the pelvis, but we can also see the different glands. Okay, we can see the different glands here. We can see the paraurethral gland. Whoops, I'm gonna hit that. Okay, hit the paraurethral gland, the vestibular glands, okay, and the vestibular bulbs. Okay, be able to identify those on an exam. Okay, the breast itself. Okay, let's talk about the breast. This is a mound of tissue overlying the pectoralis major muscle on the chest. It enlarges at puberty and remains so for life. There is a gland within the breast tissue called the mammary gland, develops within the breast during pregnancy, remains active in lactating breasts. Okay, so you can, as long as somebody is feeding on a lactating breast, it will continue to produce milk as long as someone is feeding on it. So you do not have to just have a child in order to lactate. You can lactate for many, many months and years after giving birth, as long as someone is nursing, or as long as you are maybe even pumping milk. Okay, that's what this next area here says. It says atrophies when a woman ceases to nurse. So when a woman stops nursing a child or pumping milk, then the lactation will cease. Okay, there are two principal bodies of the breast, two principal regions of the breast. The first one is called the body. Okay, this is the conical or pendulous, okay, with the nipple at its apex. Okay, that's the shape. Okay, it has an axillary tail, which is the extension towards the armpits. Okay, there are lymphatics in the axillary tail, and that is going to be how cancer cells metastasize from one place to another through that axillary tail into other parts of the lymphatic system. Okay, the nipple surrounded by circular colored zone called the areola. Okay, capillaries and nerves close to the skin make the areola more sensitive. Okay, the non-lactating breast consists mostly of adipose tissue and collagenous tissue, and breast size is determined by the amount of adipose tissue in the breast, which is going to be genetic in nature. Okay, breast cancer occurs in 1 out of 8 or 1 out of 9 American women. It's the world's leading and most deadly cancer of women. Okay, tumors begin with cells from mammary ducts, and they metastasize through that axillary tail, okay, into the armpit. Okay, signs that breast cancer is forming is that there could be a lump, there could be skin puckering, there could be changes in the texture of the skin, there could be drainage from the nipple. These are all signs that you might want to go see a doctor to get checked out, because they could be signs of breast cancer. Okay, contributing causes of breast cancer. There are 2 major genes that are being researched, and those are the BRCA1 and BRCA2 genes that we know that cause breast cancer when they have mutations. Okay, most breast cancer is non-hereditary. Okay, but there are forms of hereditary breast cancer. If you have family members that do have or have had breast cancer, there you do run a higher risk of forming breast cancer. Okay, risk factors of breast cancer: aging, exposure to radiation, carcinogenic chemicals. This is basically risk factors for any kind of cancer, not just breast cancer. Excessive alcohol and fat intake, smoking. Okay, over 70% of cases lack identifiable risk factors. So it's one of those that doesn't necessarily, like, if you smoke, you run a very high risk of lung cancer, right? Breast cancer isn't necessarily like that, in the sense that we know to stay away from certain things because it can directly lead to breast cancer. Okay, tumor discovery is usually during an examination of some kind. Okay, could be during a self-examination. Okay, which women should be giving themselves self-examinations all the time to just check for any abnormalities or something that doesn't feel like it was normally there. Okay, mammograms. These are x-rays of the breast. Okay, they begin typically in the late or mid-30s, okay, which is your baseline mammogram. Okay, once you hit ages 40 to 50, you want to get those mammograms every 2 years. And once you hit the age of 50 and older, you want to get those on a yearly basis. Okay. Treatment of breast cancers include lumpectomies, which is the removal of the tumor in a breast. You can have a mastectomy, okay, which is the removal of breast tissue or breast tissue and some axillary lymph nodes that go into the armpit. Okay, you can have a radical mastectomy, which is a removal of the entire breast, removal of the underlying muscle and the lymph nodes as well. So that's a radical mastectomy. It's rarely done as it generally does not improve the outcome. But surgery is followed by radiation and chemotherapy. Okay, that's typical of any type of cancer surgery. Whenever they go in and remove a tumor or remove an organ that has had a tumor, they will always follow up with radiation or chemotherapy. It's not just for breast cancer. Okay, there are breast reconstruction surgeries that they can do by taking skin and fat and muscle from other parts of the body and reconstruct a breast. And you'd be very surprised at how well those actually go. Okay, so let's talk about the reproductive cycle and the formation of ova. Okay, so the sequence of events from fertilization to giving birth and returning to fertility is what we call the reproductive cycle. Okay, the sexual cycle, on the other hand, these are events that reoccur every month when no pregnancy occurs. Okay, so the reproductive cycle is the sequence of events from fertilization to actually giving birth and returning back to fertility. Okay, that does not happen very often. Okay, especially nowadays, people only have maybe 1, 2, or 3 kids nowadays. Okay, it's very rare for people to have 3, 4, 5 children now. Okay, but back in the day, okay, it was very, very common to have 3+ children, in a household. People got married a lot earlier than they do now, had a lot more babies at a younger age. But the reproductive cycle is that. The sexual cycle, that's the thing that happens every month, okay, and when no pregnancy occurs. That's what we all are kind of used to happening the majority of the time, and the reproductive cycle occurs rarely, right? The sexual cycle consists of 2 interrelated cycles controlled by shifting patterns of hormones. Okay, we have the ovarian cycle, which is one of those cycles, and the menstrual cycle, which is the other. Okay, the ovarian cycle occurs in the ovaries, and the menstrual cycle occurs in the uterus. Okay, Oogenesis, or Oogenesis, however you want to pronounce it. I've heard it pronounced both ways. This is ova production or egg production. Okay, and just like in meiosis that we spoke about with spermatogenesis in the last lecture, okay, these are going to produce haploid gametes, right? They're going to have half the genetic information. So an egg will have 23 chromosomes rather than 46 chromosomes because we want it to join with another gamete, sperm cell, and create a cell that has 46 chromosomes, right? So meiosis is going to produce a haploid cell or 4 haploid cells at once with 23 chromosomes. Okay, it's a cyclic event that normally releases 1 egg each month. Okay, that reproductive cycle. Okay, this is accompanied by changes in hormone secretion. Okay, when this occurs, hormone production will change. Okay, histological structures of the ovaries and uterus will change, and uterine changes result in a monthly menstrual flow. So these changes will bring about what we call the menstrual cycle. Okay, so the sexual cycle averages to around 28 days. Okay, again, most females on average are about 28 days menstrual cycle or sexual cycle. And it could vary. It could be shorter, It can be around 20, or it could be longer, maybe 45 days, but on average, it's somewhere between there. Okay. We want to know the basic hormonal control, like hierarchy or the flow of which glands are going to control the sexual cycle. So it's going to begin with the hypothalamus, which is going to innervate the pituitary gland, which then controls the ovaries, which then controls the uterus. Okay, that's basically how the hormones are going to be produced. The hormones of one will cause the hormones of the other, and then the next, and then the next. Okay, so hormones of the hypothalamus will regulate pituitary will regulate the ovaries secrete hormones that are going to regulate the uterus. Okay, the cycle begins with a 2-week follicular phase. Okay, so menstruation occurs during the first 3 to 5 days of this cycle. Okay, the uterus replaces lost tissue by mitosis. Ovulation occurs around day 14. Okay, a lot of people, when trying to plan out, the best time to have a baby or best time to try to have a baby, okay, they think maybe it's more towards the beginning of this menstruation cycle. It's actually dead in the center. Okay, so 2 weeks after your previous period would be the best time to try to have a baby. Okay. In the next 2 weeks, which is what we call the luteal phase. Okay. In the luteal phase, this is when the egg gets released from that follicle and it awaits a sperm cell. And if pregnancy does not occur, that's when we have a breakdown of the endometrium and menstruation begins. Okay, that flow of blood begins. And then when that is finished over about a 4 to 5 day period, the cycle starts over from the beginning. Okay, and I'm going to show you a graphic on that so that you understand a little better. Okay, so here's our ovarian cycle, and you can see the different hormones that are being produced during different times of ovulation. Okay, so here's day 1 of the sexual cycle. Okay, your ova is in the primary follicle, still inside the ovary. Okay, about 3 to 5 days into the sexual cycle, you're into your secondary follicle in the ovary. 7 to 11 days, you're in the tertiary. All right, around day 14 is when that follicle ruptures, releases the ova into the fallopian tube, and that ova sits in the fallopian tube for a couple of days until it either gets fertilized or it does not get fertilized. And if it does not get fertilized, then the last 2 days, that lining of the uterus is shed, that endometrium is shed, and the cycle starts over again. And you can see the different hormones that are present during different times. Okay, during this rupture of the follicle, we see that luteinizing hormone, LH, luteinizing hormone, is going to be produced the most, and follicle stimulating hormone will also have a spike. Follicle stimulating hormone will also have a spike during that 14-day, or during that day 14, where the follicle is erupting and releasing that ova. Okay, so there are 3 principal steps of the ovarian cycle. Okay, you have the follicular stage, the ovulation, and the luteal phase. Okay, and this cycle reflects what happens in the ovaries and their relationship to the hypothalamus and the pituitary. So if we go back one, see if I can go back one. Okay, we can see the different phases. Okay, so here's our follicular phase. Okay, here's our ovulation phase. Okay, so see if I can write it: follicular phase, ovulation phase, luteal stage. And those are my 3 phases of the ovarian cycle. Okay, this is a endoscope view of the ovary here. Okay, that is the ovary. Okay, you can see what it looks like in a living tissue. Okay, couples attempting to conceive a child, or couples trying to avoid having a child, may wish to know when ovulation occurs. Now, it's not a clear science to be able to kind of guess that. Okay, but there are some things that we can look at to see if a female is ovulating or not. So the cervical mucus becomes much more thinner during ovulation. Okay, the resting body temperature will actually rise. Okay, so the temperature of that individual will rise about 0.2 degrees, between 0.4 and 0.6 degrees. Okay, this is best measured in the morning before getting out of bed. Okay, so that you have a baseline of the temperature from day to day. You have to record this for several days to see a difference. Okay, sometimes there are twinges of pain at time of ovulation. Those are called Mittelschmerz pains or Mittelschmerz twinges. Okay, and the best time for conception is going to be within 24 hours after the cervical mucus changes and the basal temperature rises. Okay, so if you want to have a child, you want to attempt 24 hours after that occurs, or if you want to avoid a child, avoid sexual intercourse 24 hours after the mucus changes and the temperature rises. Okay, the menstrual cycle itself consists of a buildup of the endometrium during most of the sexual cycle, followed by the breakdown of that endometrium and vaginal discharge. Okay, it's divided into 4 phases: the proliferative phase, the secretory phase, the premenstrual, and the menstrual phase. Okay, the first day of noticeable vaginal discharge is called day 1 of the sexual cycle. And the menstrual phase, or the release, that the menstrual period is about 5 days on average. Some females have a much longer menstrual period, some have less. Okay, there are medications and things that you can do to reduce that, and we'll talk about those later as well. Okay, the proliferative phase. Okay, this is the rebuilding of the functional layer of the endometrium that was lost during the last menstruation. Okay, during the secretory phase, the endometrium thickens more in response to the different hormones that are present and the fact that there is an ova that has been released into the fallopian tube. Okay, day 15 to 26 is that secretory phase. Okay, the uterus is going to be soft, wet, nutritious bed for an available embryonic development, right? So if that egg becomes fertilized, we want that uterus to be the proper conditions to accept that fertilized egg during those days. Okay, so the premenstrual phase is the period of endometrial degeneration. Okay, so if a egg does not become fertilized, our premenstrual phase will continue. It'll bring about tissue necrosis and menstrual cramping. Okay, and pools of blood will accumulate in the functional layer of the uterus. Okay, then we have the menstrual phase, or the menses. Okay, this is the discharge of the menstrual fluid from the vagina. The first day of discharge is day 1 of the new cycle. Okay, so the first day of the menstrual fluid discharge is considered day 1 of the new cycle of the female. Okay, so average woman expels about 40 milliliters of blood and 35 milliliters of serous fluid over that 5-day period. Okay, again, there could be more, there could be less. On average, these are the numbers. If it's too much, it could be harmful to the individual. Okay, and they would have to seek medical attention for that. Okay, the menstrual fluid does contain fibrinolysin, which allows the blood to not clot. Okay, we want the menstrual fluid to flow out continuously. We don't want it to clot. That could cause problems with the new regenerating uterine lining. We don't want that. We want the new uterine lining to be nice and ready to receive a child if fertilization does in fact occur. Okay, some contraceptive devices that we know about are here: condoms for both males and females, diaphragms, okay, contraceptive foams, birth control pills, Nuva rings, intrauterine devices. These are all meant to stop fertilization from happening, either chemically or physical barriers. Okay, so contraception is any procedure or device intended to prevent a pregnancy. Okay, there are things that you can do behaviorally if you don't want to use a medicine or a device Okay, you can abstain from having sex. Okay, you can do that, periodically, periodic abstinence or complete withdrawal from sexual intercourse will be, the easiest ways, I guess, to prevent pregnancy. Okay, but then you have barrier and spermicidal methods, which are going to be, physical products that you either have to take or use. Okay, male and female condoms, diaphragm sponges, spermicides, foams, creams, jellies. Those are all things that I showed you on the previous picture. Okay, there are hormonal methods as well. Okay, and the way that hormonal methods work is they prevent ovulation. Okay, they prevent eggs from rupturing from the follicles of the ovaries. Okay, the pill, is going to be the most common form. Birth control pill is going to be the most common form of this hormonal method. Okay, you can do so with a patch, you can do so with an injection, you can do so with a vaginal ring, or you can just take an actual pill. All of these things will do the same thing. They prevent ovulation, okay, which is going to prevent follicles from maturing, and it's going to inhibit those hormones, follicle stimulating and luteinizing hormones, so that follicles do not rupture and mature. You have things called the morning after pills, which are emergency contraceptive pills, which are high doses of estrogen and progestin. Okay, they induce menstruation if implantation has not occurred. Okay, so that it'll force menstruation on you. Okay, it inhibits ovulation, it inhibits movement of sperm and egg, and inhibits implantation. So even if an egg is fertilized, it will not allow it to implant itself on the uterine wall. An IUD, or an intrauterine device, is a springy device left in place for an extended period of time. What it does is it irritates the lining of the uterus and interferes with implantation. Okay, there are lots of things that could go wrong with IUDs. Okay, they could cause infections, things like that. You have surgical sterilization, which is a very last-ditch effort. But for people who have already have had the amount of children that they want to have, but they still want to continue to have intercourse without any contraception, this is a way to go. This is kind of like, cutting the tubes for a male, like, having a vasectomy for a male. Okay, they can do the same thing for a female, where they clamp or cut the fallopian tubes so that ova cannot get fertilized. And that is where we are going to, no pun intended, cut off this lecture. Okay, if you have any questions or comments, please leave them in the comment section below, or you can email me. And I'll see you next lecture. Bye.